So let's talk about folate deficiency. We can talk about the symptoms, but B12 deficiency and folate deficiency are pretty much all the same, what you see. So one of the things you can see with folate deficiency, as already explained, is homocystinuria. It can cause neural tube defects in the baby, especially if the mom, the pregnant mom, is not taking supplements of folate. Lack of folate in pregnancy will also increase diabetes risk, as well as autism in the child in the long run. One thing we want to stress here is that homocystinuria treatment with folate lowers the stroke risk, but not cardiac events. That's just data we need to know. But even then, we have to think about treating it, because I have patients that came to me because they just wanted their genetics done. And I saw that they were MTHFR deficient, young guy. And I told him, okay, you're feeling good, you don't have depression, but I elicited family history of strokes and things like that. And he told me later, in that same conversation, he's had a history of stroke. So it's very important when people are MTHFR deficient, regardless of whether they feel good or not, you have to do these things. You have to treat it. And of course, maternal folic acid may lower the risk of childhood leukemia. So how do you treat it? I like to go with just diet first, but if it's super low, for myself, so long as I know that they don't have any issues with low COMT, and then I'm not afraid if it's a folate below 10, just give it to them, because you want the patient to have the ability to make all those good feel neurotransmitters instead of just depriving them of that. Because if they're feeling bad, you might as well treat them. Food sources, green leafy vegetables, fruits, and the liver. Of course, when it comes to supplementation with folate, if they don't have any folate deficiency, then it's not necessarily that you need to treat it, because there can be the risk of cancer. Why? Because that methylation cycle is not just for making our good feel neurotransmitters, it's also used for protein synthesis. Okay. Homocystinuria. So now that we understand that B12, MTHFR, and folate deficiency are the main causes of it, I didn't put here inflammation. That can still happen. The treatment's simple. Treat the B12 deficiency, treat the folate deficiency. If they have MTHFR, give them the L-methylfolate, 15 milligrams. One thing that also is part of that methylation cycle out of the homocysteine comes out glutathione. If you cannot convert the homocysteine to glutathione as well, then you should give them glutathione 500 milligrams twice a day, especially if they're complaining of inflammation, joint pains, if they had EBV, if they've had elevated C-reactive protein. We may not know where the inflammation is coming from, but it's there. So we might as well support the patient's immune system, because it's probably running out of gas, and that's why they feel bad. Okay, methylmalonic acid, I checked that. Basically, to look for elevated methylmalonic acid, there's two ways: B12 deficiency, and so give straight up B12 1,000 micrograms. But there's another way we can see where methylmalonic acid is elevated. It is the inability to metabolize B12. So this is when I get perturbed, when I see doctors in weight loss clinics shooting up people with B12. And I'm like, did they even check your ability to metabolize B12? This is very common. If you have MTHFR deficiency, you can at times see they have a poor ability to metabolize B12. So at that point, how do you know that? The B12 is high with elevated methylmalonic acid level. That means it's not working. It's not metabolizing. So at that time, that's when I give methylcobalamin 1,000 micrograms a day instead of regular B12. So, you have to think about it. Think about the correlation and the relationship of these B vitamins, that it's not just about replacing it. You got to know, are they able to metabolize it and convert it to the active form that your body needs?